What's up, everybody? Thanks for coming.
Probably give it another 1 or 2 more minutes, Dr. Fien.
Yeah, that sounds good to me.
All right.
Just pounded my coffee, so a couple minutes for that caffeine to kick in. We need some music.
We need Dr. Bide on here with his DJ skills.
Good idea.
Just bring him in for cameo appearances.
That's right. He's got some cases, let me tell you.
We should have him DJ at the ISPRD meeting, just set up a nightclub.
He would love that, let me tell you.
All right. Well, I know we're going to have a few stragglers joining us, but I want to be respectful of everyone's time. So I'm going to go ahead and get us kicked off here. On behalf of everyone at Snoasis, thank you for spending some of your evening with us this evening. My name is Matt Burns. I'm sure you've seen my emails come across. Again, appreciate your time. A couple things. Please utilize the Q&A feature at the bottom of the Zoom screen if you have any questions. We'll make sure to answer those either throughout or at the end of the presentation. Secondly, I'm hoping this presentation may spur some of you who are looking at maybe doing our Perio resident best case competition, maybe to jump in the game. This is our second year doing it. Submissions are due October 7th. If your director didn't share the information or you're unfamiliar, please reach out to me offline and I can get you those details. But that's really enough out of me. I'm really excited to be introducing Dr. Matthew Fien this evening. I've gotten to know Dr. Fien over the last couple of years. Extremely talented and gifted clinician. More than that, he's just an amazing human being. And most recently, he added rocket scientist to his portfolio. So I'll let him share that story. But he asked for not a long introduction. So with that, Dr. Fien, I'm going to go ahead and kick this over to you.
Thanks, Matt. And thank you to Snoasis for inviting me to share some of my cases and my experiences. And of course, thank you to all the residents. So when Matt came up with this idea to do a resident webinar, I was really excited. As you know, I've been there. I've been through the process of dental school and the postgraduate residency. And so not only do I want to share some of the, cases that I've gone through, but I'll also try to share some of those little tips and tricks that, just getting through the day-to-day that I think will be very, very helpful. If you guys hear my dog in the background, he's acting up a little bit, but I think we'll be able to quiet him down, hopefully. Throw him a bone or something. One of the things I always like to start with in most of our lectures is to try to make it relatively, conversational. So feel free, if you guys have questions about any of the cases or any of the ways or techniques that I'm going about some of these cases, please feel free, put them in the chat or put them in the chat. I think is probably the best place for it. And I will try to answer as I go if it's relevant, or else we can always spend some time after discussing some of the cases. I'll tell you that my own experience as a resident was really an amazing experience. As we all, are going through this, it's a very stressful time in your life. I think I was very fortunate being born and raised in South Florida. I went to dental school at Columbia University. And then being very, close with my family and wanting to be, with my soon-to-be wife, I moved back down to Florida, and I was very, very fortunate to have some great mentors at Nova Southeastern University. And so I think this would be kind of cool with the people that are on right now, just to kind of write in the chat group or in the Q&A. We'll say in the chat, where you're from, what school you go to, and what your specialty is. I think that would be kind of a fun exercise just to sort of see who's online, because, nowadays with social media and us being able to kind of share cases on Facebook and Instagram, it's so much different than the way it used to be. And when we wanted to get access to cases, or we wanted to see new things, we would be searching through the journals. And I don't feel like I graduated that long ago, but when you start looking at the dates, I graduated back in 2009. So it's really one of those things where time will fly by the second you leave school. So make the most of it. But understand, everything comes to an end. So, take advantage while you're here. And the fact that you guys are on this right now, obviously is a testament to how ambitious you guys are. And I got to say, we have a very bright future ahead of us, whether you're OMFS, Perio resident, AEGD, GPR resident, we have a great field. But the thing is it's very easy for us to sort of get off track and sort of lose our focus. So I'll tell you a little bit about my story. Like I said, I started my Perio training in 2006. And one of the things that I loved about Perio residency was our surgical seminar series. And we would sit in that room and we would go over cases, and basically someone would present the case and then we would go around the room. I'm sure you guys are familiar with this sort of a format, and everybody would sort of say what they wanted to do. And I sort of got known for basically going with very predictable, straightforward sort of treatment plans. And one of my buddies had a very thick Alabama accent, and he would always say, after I would, comment on the case, he would say, "That's fine odontics." And so that really stuck with me. And when I came out of training, I'm treating real people. I wanted to do things that were as predictable as possible. Not just for myself, but for my patients. You don't want to be dealing with post-operative complications. You want to do things that you would really want on your own mouth. Okay. And I know while you're in residency, sometimes you get forced to push the limits, and that's great. But in reality, you got real people that are in your chairs every day. So try to do things that are the most predictable as possible. That really lowers the stress. I'll tell you one of the biggest mistakes that I probably made as a resident or as a graduating resident is, of course, you come out of school, you have so much debt, you have so much, time that you spent in school. And I went into a little black hole for probably about 5 or 6 years. I was in this black hole where I took some CE courses that were required. I didn't take very focused CE, but I really think that was an opportunity where, I got great experience in real life, and I was just doing, dozens of surgeries a day and really, learning hands-on, because there's only so much you can learn in a residency. You only get to follow your patients for so long. So I think, looking back, I really wish I would have done more focused CE right out of school. But what I did do is I took a lot of photos of my work, and I was really always analyzing my work. And we'll talk about that in a second. But this is my family, and they're really everything. So again, getting back to the idea that I want to be with my family on the weekends. I want to be with my family at night. I don't want to be stressed and worried about, cases that I was trying to push the limits and worried about complications. And we've all had them. Okay. It happens to the best of us. Anybody that tells you that they don't have failures and they don't have complications, that they haven't done enough cases, or they're just plain out lying. So, unfortunately, with social media, not all of us share as many of our complications as we probably should. And there's maybe a lot of reasons for that. I know for me, I just hate when things don't go right. It is absolutely terrifying. When you have patients that come in post-operatively that have large infections and they're uncomfortable and they want to know why things aren't working. And to me, it was always about trying to minimize that. And I had a lot of stress coming out of school because I felt like I had to be good at everything. Right. And what I sort of learned, and I really owe this to my wife, who's really been sent, very, very critical in me kind of learning about myself and about what cases to treat, what not to treat. There's an old saying, you make more money on the cases that you turn down. And it's very, very true, because you can't fix everybody. But one of the things she said to me that really always stuck with me is that you are the airplane pilot. The plane cannot take off without you. And so when you get to the office right out of school, and, you got office managers and staff and people throwing things at you, you have to just take a step back, because ultimately, this is your life. It's your right to treat whoever you want to treat. And just because you're periodontist, for instance, doesn't mean you have to do every case. And just because you're an oral surgeon or whatnot, you have the ability to punt and to refer out. And a lot of times you'll see patients really do respect that. We have a hard time, coming to that conclusion. But once I learned that, and I learned that I didn't have to be everything to everybody, and that I was in control of my own destiny, I really feel like I really grew as a person, and also grew as a clinician, because I was able to focus on the things that I love doing. And so whether it is, implants or bone grafting, or just traditional perio surgery, or I have buddies that are oral surgeons, and some of them focus, on orthognathics versus, traditional wisdom teeth type of offices. You got to love what you do. So find that passion. And we're very lucky. There's so many different subspecialties within dentistry. So you don't have to be, lock yourself into a corner and say, this is what I have to do. If you're not happy with what you're doing, then find something else, find your passion, because I'm sure you will be able to do that. There's so many, great things going on in dentistry right now. So I do feel like we're all very, very lucky, but don't lose sight of that. And really the theme of this presentation is going to be, doing things that are very, very predictable, and also using materials that just have a big versatility, so that we're not always having these decisions that we have to make on every single case. What material, what type of bone graft, what percentage of cortical to cancellous. These are all things that we really just want to kind of streamline for the most part, because we see a lot of cases in real life. And like I said, I went into a black hole, a black cave, but really what I was doing during that time is I was sort of finding myself. And the way I did that was by taking lots of photos. And of course, I had a full frame camera when I was in training, when I got out, and I was working at multiple offices for a while. I took a lot of iPhone pictures, and I still have those photos. They maybe aren't, post worthy per se, but I learned a ton from that. And when you get out into the real world, obviously we need to make money. We need to pay the bills. You want to take care of your family. You want to have, kids and all that. And so, yes, it's great for getting better, but it's also really good for, case communication and selling cases. Just having a portfolio of your own work is by far the best way to sell cases. And I can walk into a room now, and I don't tell patients that I have an Instagram account, because it's very bloody. You don't want patients to necessarily see that, but just having nice pre and post ops gives the patients confidence that you know what you're doing. And so, you don't have to be a great photographer. I don't consider myself a really great photographer, but I take a lot of pictures because it's what's helped me grow. And it's, the ability to take sexy photos is great, but really that's not what it's about. For me, I love the idea that I have on my phone probably about, here you go, 38,000 photos. And I can really search for any case. I had a case today that was in the office, and I knew I'd seen the patient before. I was able to go back into my phone and just pull the case up to see where we were, 5-6 years ago when I did this case versus now how it healed. And so for me, huge benefit for all of you would be document your cases, and if you don't want to show them to anybody, you don't have to, but for yourself, for learning purposes, the more you document, the better off you're going to be. And I do regret those years where I was taking those iPhone pictures and not using the real camera. But I will say, even the iPhone photos are better than nothing. So with that said, I really want to dive in here and kind of talk about, not only what we're going to do to manage a lot of the cases that I'm going to show you, and a lot of it revolves around the Bioexclude membrane. Israel Putterman and I are partners. We teach a lot of courses together, and we always joke that this is our hot sauce. It's one of those materials that you can kind of find a use for it in so many different procedures that we have. And we'll talk about why that is. But one of the best lessons I probably learned early on from one of my mentors, Dr. Garfinkel, was the carpentry is the easy part. It's the planning. It's knowing where you're going to end up and making that decision early on. And everything else will come. And I didn't really believe him, because when you're in training, you don't have the hands yet. You don't have the skill set yet. But the carpentry does come. After a couple of years, you start to get better. And I can only imagine, looking back at the type of surgeries I was doing as a resident versus what I'm doing now. And I can only imagine what it's going to be like in 10 years after having another 10 years of experience. So I think just keep in mind, we're always growing. We don't have to know everything yet, but learn as you go and take every opportunity you can to get better. And again, the photography for me is huge. I'll tell you how I started using Bioexclude. And again, since this is a resident webinar, it's kind of coincidental, but one of my co-residents was working at an office, and he was moving back to Washington, D.C. And he's called me up and he said, Matt, I got a great office. They need a periodontist. I'm leaving. Can you take over for me? And so I took his word for it. I started working at the office. I still work there to this day. It's been about 6 or 7 years. But once he left, I had to take over, and I had to do a lot of his uncoveries. And both he and I still do mostly one-stage implants, but at the same time, there are cases where we'll bury implants. And so I would do a lot of his uncoveries. And this was one of those cases where, I'd uncover the implant or try to uncover the implant, and I need a stud finder to find the implant. and I'd take an x-ray to make sure that the implant was there, because the implant would be buried under mounds and mounds of bone. So I went and looked at his notes, and he was using Bioexclude, which I had never heard of at the time, but he was using it on almost every case, just putting it over his implants. And this is, again, iPhone picture, but I went and sent it to him, and I said, I cannot believe how much bone you're growing over these implants. And he said, oh, you got to try this stuff. It's super easy to handle. I kind of disagree in the beginning, because there is a learning curve. And that's one of the reasons why I think Snowasis is so smart putting together a webinar like this, because there are some things that you have to be aware of. It's a little different than other membranes out there, but what it's providing you is this immunoprivileged material that's antibacterial, that's very, very safe. And once you get the hang of it, it is actually very, very easy to use. And it has so many different applications. So that's really what we're going to focus on tonight. But that's my story on how I started using this material. And so, like I mentioned, immunoprivileged, there's studies that show it's as antibacterial as like an antibiotic, like tetracycline. And it's really the only amnion-chorion membrane on the market. Now, what is interesting is a lot of other companies are trying to copy the product now. And that really just tells you one thing, that tells you that this works. When so many different companies are trying to come up with their own version of a material, I take that as a really big compliment, and really tells you a lot about what this product actually does, because there's so many great clinicians throughout the world now that are using this product and have had the same sort of experience that I've had. And so that's what we're going to share today. This material, like I said, really only one like it. I love the personality and the culture of the company as well. That really does go a long way. And you'll see that, very, very easily, a lot of smart things going on here. So on the actual box, they show you all the different sizes they have. And I know that can be kind of confusing, because it does come in a lot of sizes, but those are actually true to size, the pictures on that box, which I thought was very, very smart, because sometimes you have a defect and you don't know, do I need a 20 by 30? Do I need a 15 by 25? And so the fact that they have that on there is a pretty smart idea. And then, of course, this membrane is dual-sided, and everybody knows it as the membrane with the smiley face. And the reason for that is because there's no up or down. And of course, the smiley face is symmetrical. So whether you have this material facing up or facing down, it really doesn't matter. So very, very, easy for us to start using this and not have to worry about, the placement, whether or not there's one side that's up or one side that's down. And then again, the sizes being a material that has so many applications, there's a reason why that comes in so many different sizes. And as I'll show you, the 8x8, not something I use very often, but if I have a very small tear in the sinus membrane, or if I'm doing maybe an immediate implant and I'm grafting particulate into a socket, I can use that 8x8 right over the top. Very, very easy. At the same time, the majority of the cases, I'm probably using the 15 by 20 or the 15 by 25. In a case where maybe I'm grafting a buccal plate, I can tuck that membrane in and fold it over the buccal occlusal line angle. And I've kind of been obsessed with the 20 by 30s lately, because I've been using them on top of a lot of my collagen membranes for larger horizontal GBRs. And I'll show you that as well. So first and foremost, starting off, socket preservation is one of those procedures that once you get out, whether or not you're an oral surgeon, you're a periodontist, or graduating as a general dentist from a residency, if you do extractions, you have a huge reason for us to do socket grafting. We know that the science proves that, having that bone graft in the socket is going to prevent the bone from shrinking. It's still going to shrink, but it's going to prevent resorption to a point where we have to go back and start doing ridge augmentation, which is a lot more difficult procedure. Okay. And so for almost every case, I'm going to do some form of socket grafting. Unless there's a really large infection that I can't degranulate, I'm almost always socket grafting. But I don't want to start raising large flaps. I don't want to start pulling for primary closure. I want to be able to use a material that's very simple to use. And I know some of you are thinking, because I'm sure you guys are all in the mindset of reading lit and knowing, whether or not we actually need a membrane in a case like this. The bottom line is, yeah, the buccal plate's intact. But again, I'm not experimenting on my patients. And I published an article in the IJPRD with one of my good buddies, Dan Gober, about 10 years ago, where he actually took a photo of a case just like this, where he did no bone grafting, no membrane. And the reason why it got published was because he was so good about getting the patient in. And so he basically got a picture of the patient of this occlusal view every single day for 7 days. And it's just showing you the soft tissue healing over that, even without bone, even without a membrane. And so I understand that. But in real life, do I want to take that risk of leaving my bone graft completely exposed? I don't, because you never know who's not going to treat well. You never know when things are going to get exposed or when the patient's going to start losing any bone graft or they lose the blood clot. And it's really a little bit risky in my mind, having an implant in place and not having something to hold that blood clot and hold that, that graft in place. And so in these cases, I think it's a no-brainer. I want something very, very simple. And that's where I'll use the Bioexclude. And you can tuck it into the buccal, or in a case like this, I won't even do that. I'll basically just lay it over my graft and I'll very gently tuck it on the buccal and the lingual side. And just like my buddy, Dr. Modaris, who referred me that office in that first case, I started seeing that now all of a sudden, all of my implants had this nice solid layer of bone over the top, no remnants of any particular graft material. Things were just healing very, very well for me. And a lot of people on Instagram, a lot of people in real world, they're using this material because of that, because it's so simple to use. We have a lot of these guys are really close friends of mine. And some of them are doing really large surgeries. Dr. Holtzclaw does, zygomatic implants all day long, and he's using it for his full arches. And I'll explain to you how I'm using it as well. Because of the handling of the material, it is really so beneficial for so many of these different applications. But like I said, it doesn't handle like a collagen membrane because it's not a collagen membrane. It's amnion-chorion. It's a lot more delicate. And so I always like to show this video just to kind of describe to you how I will perform this type of procedure, on most of my socket grafts, and a lot of times on social media, we'll post the bigger cases, but I'm certainly using this at least 1 or 2 times a day. And in a case like this is exactly how I'll do it. So even if I have a mild buccal dehiscence or if the socket's completely intact, I'm going to go ahead, I'm going to degranulate, I'm going to irrigate, I'm going to pack my socket with bone graft, a particular bone graft, usually a freeze-dried bone allograft. And then we're going to apply the Bioexclude. Now, the way to do this is you want to handle this material when it's dry. Once it gets wet, it starts to sort of suck down. So this is called the 2-instrument technique. I'll use a dry tissue pickup or cotton plier typically, and then I'll use a periosteal elevator that I'll dip in saline. And so you hold the material in place with the cotton plier, and then you can just gently tuck this material right under those flap margins. And so I'm not really elevating flaps. If you saw in the beginning of the video, I'm just maybe 1 millimeter or 2, just enough that this material can get tucked in. And if you notice, it's sort of folding up on itself. And that's fine. That's the benefit of this material, that we can certainly have that happen. We don't have to worry about trimming it to the perfect size, but more importantly, we're not raising big flaps. And then another trick that I use quite a bit for my sockets, even when I'm not using this membrane, it's a great trick, is to always suture from the inside out. So you just spent that extra 1.5 minutes getting this material in place. Go ahead and suture from the inside of the socket to the outside. If you go from the outside to the inside, you always want to grab that membrane and pull things out. And then you have to start over. So I always encourage people to suture from the inside out. Now, the other thing that this does, and you'll notice as I go to tie this suture here, is it sort of everts the flaps a little bit, okay? When I say evert, I mean it kind of takes the flaps and actually folds them in. And that kind of holds everything in place really, really nicely. But again, this is how I'm leaving the majority of my sockets, whether or not I placed an implant or not. If there's a mild dehiscence, I'll still do this. I have no issue doing this. Now, once I start having more severe defects, then maybe I'll add other adjuncts to this type of procedure, which we'll talk about in a couple of minutes. But for a lot of my simple cases, this is how I'm approaching it. And that's because of how easy it is to use, but also because I know that this is giving me those antibacterial properties. It's also immunogenic, right? It has growth factors in it, which is very, very beneficial. Now, when you do leave this exposed, you don't want to have the patients rinse for a couple of days. So usually about 2 to 3 days. I don't have them brush the area. I don't want them cleaning. I don't want them doing anything really. I just don't want them to disturb the area. And that's very important because patients don't know. So they'll start wiping things away. They'll start kind of moving things, playing with the sutures, try to have them just avoid it completely. And then of course we tell them not to rinse with Paradex. Now I know a lot of us have gotten away from Paradex anyway, but I think it's worth mentioning. You don't want the alcohol and that to break down the material too quickly. So I typically have them not rinse with anything for about 7 to 10 days. If they must rinse with something, warm salt water, gently, but for the most part, I just have them not rinse at all. Now, if I do have a more advanced defect, maybe a mild to moderate dehiscence, where I feel like I need to have this material tucked in, and the real reason for that is because I want to pack my bone graft into that buccal occlusal line angle. Then I'll raise a small envelope flap like you see here. And one of the things that I'll do in this case is I will just, like I'm showing here, create a little pouch and then tuck the membrane in. Now, again, this material is very delicate, so you want to place it when it's dry. You don't want it to get wet. And the biggest mistake that I used to make with this material is that when you're using a collagen membrane that's very stiff and you try to tuck it and you get hung up, you can take it out and you can kind of, start over and tunnel your flap. With this membrane, once it gets wet, it starts to fold over on itself. So you really don't want to do that. You got to make sure that your tunnel prep is good from the beginning. And so you want to make sure that you elevated your flap's full thickness laterally to the defect enough so that your membrane can sit in there. Again, I don't typically trim this membrane. If you see in this photo, I did actually trim it. And the reason why, and this may be off label, but I'll tell you it works for me very well, is I'll cut little pieces off of the membrane and I'll mix it with my bone graft in some cases. Why not, right? Having extra growth factors into the mix. And I find that this really works very, very well. But you don't really have to trim it because it's immunogenic in nature. And we're using this for gum surgery and periodontal regeneration all the time. There's no issue with this membrane touching the adjacent teeth, which makes it very, very simple to use as well. But here you go, just tucking this membrane in. Again, I'm going to fold this over the buccal occlusal line angle, but really the bone that I want to maintain is that buccal occlusal line angle. So I'm going to be packing my bone into that membrane and then folding it over. And so I typically will pack most of my bone into the socket, maybe 90% of it. Then I'll place the membrane, and then that last 10% of bone will get packed in before I fold this membrane over the buccal occlusal line angle. If this membrane hasn't gotten wet with blood at this point or saliva or something, again, I'll use the wet instrument like a periosteal elevator dipped in saline, and I'll just sort of apply that instrument to the material and it will suck down very nicely like saran wrap, which is why, a lot of people love this membrane once you get the feeling of the handling of it. And this is how I'll leave it, just like I showed you in the last picture. And so this is something that I'm doing all the time. Here you can see the picture of the Bioexclude being cut up, just putting it in with the bone. Again, not because I'm worried about the material folding over on itself or touching the adjacent teeth. I just want to make sure that, if I have the ability to add more growth factors to the bone, I'll do that. And you can see how I'm leaving it just like I did in all those other cases. So it's just an internal cross mattress. Sometimes I'll place an additional suture on either side. And if you notice in most of these cases, I'm using like a PTFE suture. You can also use resorbable sutures like Glycolon. I think Chromic Gut does resorb a little too quick for this type of thing because you just risk losing some of the material. But certainly any suture material really will work. Anything that doesn't wick bacteria is going to be fine. And then just watching the healing of these things, it always impresses me because you open this up, no remnants of any particular graft material, completely regenerated, that small defect that we had. But in this case, it wasn't so much about regenerating, it was more about preserving. And even though there was only a mild buccal dehiscence, that residual buccal plate was very, very thin. And I've done tons of these where, in my former life when I wasn't really grafting everything, and you always get shrinkage. Even on a Clydesdale who has really, really thick bone, you just never know who's going to shrink. So that's really the biggest question we have, who to treat. Well, I'd rather treat than not treat. And if I have to go back and graft later, at least I know that I gave it a shot at the beginning. And that shot was painless, no morbidity. Patients do really, really well. So if it does shrink and I have to regraft it, okay, at least I tried. And, that's sort of a patient management issue. Nobody's going to be 100%, batting average when it comes to getting the results that they want in bone grafting. But the idea is to minimize the chances of getting that shrinkage and avoiding the larger procedures later, because that's where, patients do get morbidity and do get a lot of swelling and discomfort after surgery. So we try to avoid that. Now, something I've been doing a lot more lately is actually doing more of a double layer. And I like that because it makes the handling a little easier. It's a little easier to tuck it. And so what I'll actually do is just take that membrane, just like I showed you in the previous case. I'll create a small circular incision, raise a full thickness envelope flap, knowing that I want to tuck my membrane in. And I'll just fold this over on itself. So this is like a 15 by 25, and I'll just fold it right over. And that just makes it a little easier for me to tuck it. Okay. Once I do that, same sort of procedure. This is a Laurel modification, but you could really just do that same sort of suture I just showed you, where you're going from internal to external. It works really well. I leave this exposed. You can see in this case, the healing at about 7 days. And what's going to happen now? This is going to fill in. We know soft tissue granulates in at about 1 millimeter a day. So a couple of weeks later, we have it completely filled in with new keratinized tissue. And I know a lot of people are using non-resorbables for this, and that's okay. You can use non-resorbables, but it's a patient management issue. And especially for me as a referral practice, patients will sometimes get referred to me. I don't want them walking around necessarily with something sort of flapping in the wind or a PTFE membrane that has to be removed. So it's a lot easier from my standpoint if I have a material that I know I can leave exposed that's going to protect the bone, and I'm going to get good results with it. And believe it or not, I actually placed an immediate implant in this case. Okay. And again, it's completely covered in bone. So I had to do quite a bit of bone removal. Not ideal, but I would much rather start off the restorative phase of treatment with bone to the top of that implant than to be deficient. Okay. So this is something to think about. You know, when you start to see the results like this, where you have this beautiful bone that's healthy, that's bleeding bone over your implants that were placed 3-4 months prior, it's sort of like a no-brainer. Why wouldn't I want to use this, you know, and get those sort of results? Now, all of the cases I've showed you already were cases where I left things exposed. And as residents, I can't impress to you enough how important it is to think the big picture, because the majority of the socket grafts that I do like to leave things exposed. Sometimes we have doubts and we say, well, I just need too much bone, and I'm going to turn it into a GBR right away. But at the time of a tooth extraction, you don't have enough tissue to work with. And so you can do a periosteal release and you can pull things closed and get dual layer closure. But this is what you ends up happening is you end up having this big Meco-Gingival defect. Now, does the bone underneath heal well when you do this? Sure, you get great bone, but you've completely displaced the Meco-Gingival junction. I like to call this the self-inflicted Meco-Gingival defect technique. And I'll tell you, there are cases where I still will do this, knowing that I have to go back later and fix it. And this is not an old case. This is actually pretty recent. But the majority of the time, I really prefer not to go this route because, of course, it's a lot harder to fix. I have to then do some sort of soft tissue manipulation. In this case, look at the bone, how it healed, right? So like I said, you get great healing when you get primary closure, but you have to be able to then adjust the soft tissue later on. And it's not even so much that it's so technically demanding. It's just that now you have to warn patients, oh, by the way, remember that implant procedure that I told you was going to be so easy? Well, all of a sudden now it turns into a soft tissue graft, which obviously is going to be a little bit more, just uncomfortable for patients. They're going to have a lot more discomfort. And, then it's a battle of just getting it back to where you started. And so in this case, I did what's called the modified roll technique. I took a little bit of tissue that was under that palatal flap and rolled it under the buccal. And I did pretty good, but not nearly as good as I would have done if I would have left this open. And so just keeping that in mind, I do get primary closure sometimes. But the majority of time, if I have a material like Bioexclude that I can leave exposed, I think there's a huge benefit to that. And even if I have to go back and graft later on, I have enough tissue to work with. So I don't end up with this sort of Meco-Gingival defect like you see on the bottom right of your screen. Okay. And just because I am, not getting primary closure, it doesn't mean I can't raise flaps. So here's a socket. I knew from the x-ray, and I'm not going to show you the x-ray because it'll ruin the surprise, but I knew from the x-ray that this was a pretty large defect, but I'm always still extracting the teeth first before laying big flaps. Okay. I want to extract the tooth. I want to try to, start degranulating from within that socket bone sound to see where the defect is. And as you can see here, I look pretty good because I have this nice thick buccal plate and I have, the buccal occlusal line angle is intact. But what happens when you start looking closer here? And you start to see why I placed the vertical incision, because this defect was just really massive. It was almost like a lateral wall sinus lift, okay? And in these sorts of cases, when the defect's within the housing of the bone, this is when Bioexclude really, really shines because of how drapable it is. And here's a little demonstration that we did for one of our courses, just showing how stiff the membrane is when it comes out of the packaging. When it's dry, it has that memory. And then as soon as you try to manipulate it in its dry state, it'll sort of bounce back, right? See that? It's just bouncing back. But once you get it wet with some of the saline from the bone or from the blood, it does start to suck down. And so again, once you get it in place, that's when I'll use a periostea elevator like I'm showing here, and I'll get it to suck down on the native bone. And so I do this for a lot of my lateral wall sinus lifts, almost all of them. For the actual lateral wall, I'll use the Bioexclude over the top to help confine the bone graft and act to keep soft tissue from growing into my graft. But for large defects like this, especially ones within the housing of the bone, this works great. And again, just because I raise the flap doesn't mean I need primary closure if I have the right biomaterials. So at day 0, I'm leaving this completely exposed, showing you what it looks like at 1 week after I'm removing that PTFE suture in this case, and then at 4 months. And again, I take a lot of pictures because I like to prove that things work. And this is one of those cases where I flapped it open to see how that bone did. And I was very, not surprised, but I was very happy to see, the volume of bone I had, the quality of that bone. And now I can basically place that implant without having to do additional grafting, knowing that I got really complete defect fill and actually grew bone outside of the housing. Okay. And so you can see the before, middle, and after. And that's something that, sure, can you achieve that with other membranes? Yes, but this is really suited for this type of defect because of how drapable it is. And there wasn't a lot of trimming that was needed. And I didn't really stabilize this at all, other than by having the material extend beyond the defect margin so that it will adhere to the native bone on either side. Okay, so you want to have a large enough size of the membrane to do that. Of course, nowadays, a lot of people are doing the Corey technique. I've been playing with it for a while, but at the same time, a lot of these cases, I find that I can get pretty good results doing these horizontal GBRs with all resorbable materials. This is a case where I just did recently where I did a little Corey plate. And again, if I want to use a collagen membrane here, now I have to worry that it's sort of bunching up on the adjacent teeth. It's not so easy to do. And so I'll use the BioXclude in these cases, definitely, because of how nicely it will suck down over the area. And of course, it's adding all of those biological benefits that we don't get from a collagen membrane. And we don't have the risk of things getting exposed and worrying about, post-op infection and things like that. Another tool that I've been playing with, and I owe this completely to Dr. Putterman, he's been showing me these unbelievable results using the laminar plates. Now, he actually gets the laminar plates from their Maxius laminar plates. We get these from Snowasis as well. And I started playing with these, using it almost like a Corey plate in a sense, but because the material is soft and it's not as obviously as firm as like a cortical plate would be, we're usually stabilizing these with sutures, just like we would a collagen membrane. One thing I always like to point out, I'm using autogenous for all of these larger grafts, not 100% autogenous. I'm mixing it with FDBA, but I always think that that's a step that a lot of us want to skip. And I think you'll get much better results incorporating 20%, 30% of autogenous scrapings locally, not from a separate site, but locally mixed with your allografts. You're going to get much better results. So don't skip that step. But again, then having the Bioexclude available to just kind of suck down over the area is a great, great combination, of materials to use. Now, do I use it alone for bone grafting for larger contour augmentation? I certainly do. And it just depends on the shape of the defect. So here's a case where we placed an immediate and I will pack my bone. And if you look at that distal aspect of this edentulous site, I didn't really put any bone there. I probably could have. I didn't do that, but check out how this heals. Okay. Just like I showed you the case that was referred to me by my co-resident, just like those other cases where I showed you earlier on, where I'm putting bone graft over an implant or on the buccal side of an implant, you're returning to these sites and you're having complete bone regeneration of that buccal occlusal line angle, which is so critical, and having your implants sort of buried in the bone. Here you go, another contour augmentation, I call this, where I place my implants. And this is something earlier in my career, I got to tell you, there's probably tons of cases where I was in this situation and I decided not to bone graft it because, hey, it looks like the implant's covered in bone. And now that I've been out close to 15 years to age myself, I got to tell you, you see these cases, and it's usually on the 3rd or 4th year when they come back, and all of a sudden the implant threads are exposed or metal of the abutment is exposed. And you say to yourself, wow, I wish I would have done more at the time of placement, because you're already in there. You already have access. You have good bleeding. You have good blood supply. Again, I can scrape some autogenous right from the area locally. I can lay the Bioexclude over that buccal occlusal line angle because I have that nice concavity to work with. I don't do any stabilizing sutures. I just, get closure in a case like this. And you can see here, here's the healing at about 5 months. So certainly got good regeneration in a case like this where, previously I maybe would have ignored it and that would have bit me later on, or maybe I would have tried to use, a stronger collagen membrane that required me to stabilize it, becomes a much more difficult procedure. So there are certainly a lot of indications where you can use this membrane for guided bone regeneration on its own. And as you see, the results really do speak for themselves, because in all of these cases, I'm getting bone to fill in those defects. I mentioned already, because of the drapability of this material, great for these lateral wall sinus lifts. I don't do nearly as many of these as I used to do now that we do so many internal lifts, but no better material to lay over that window, because it conforms so nicely. You don't have to worry about it touching adjacent teeth. And then the other application that I think people don't talk about enough is these full arch applications, because it's very difficult, especially around the corners of the mouth when you're trying to bone graft, to be able to have a membrane lie down around that curvature. And so using the Bioexclude in these cases is sort of something that I do almost every time. And a lot of these defects, you may say, oh, they may fill. Well, again, I'm treating real patients. So I want to use every bullet I have in my gun when I'm in there, when I have it flapped open, to be able to give the patient a longer, prognosis, a better prognosis long-term. And the Bioexclude does that, because now I have the ability to feel a little bit better if things open up, because I have that Bioexclude covering over. And again, it's antibacterial. So what could really, go wrong? And this is like a 10-year follow-up on this case. Patient's doing very well. You see, it's very tissue friendly. We have beautiful keratinized tissue around those implants. The patient's doing a nice job keeping it clean. But this is just something that I really incorporate into a lot of these cases. Again, imagine trying to lay a collagen membrane, even the most, even a membrane that handles really, really nicely, a collagen membrane is still not going to lie down as nicely as this will once it gets hydrated. And so you see all around those implants and those sockets that I had some buccal defects. I went ahead and used the Bioexclude. Now I'm going back and I'm uncovering the implants, and I have bone literally occlusal to those implants, because I grafted everywhere while I had the opportunity to do that. Nowadays, a lot of the time, if I'm doing a case like this, right, it's pretty obvious that we need to bone graft here. We have, very, very thin buccal plate. We have large defects, and I can go ahead and do this. Now, this case, I'm never going to be able to open up to see how it did. Hopefully, I'll get the patient in soon to get a CT scan. But I do have post-op views, with the patient once we remove the hybrid about 4 months later. But again, just using a material that's super easy to use, that can conform really well, that doesn't necessarily need stabilizing sutures or, tacks and screws, is making my life easier, but also giving benefit to the patient. And just one more example of that. And I'll do this a lot of the time. I use these mini implants, not as a permanent solution, but for like my locator cases, I will often place these 2 mini implants just to keep pressure off of the ridge. And so that the patient's a little bit more comfortable with their immediate denture, because as we know, they're never comfortable with that immediate once you've tabled the bone, as you see, as I did in this picture on the left. But look at that implant on the right side. And I have it's almost right into the septum, and that socket has a buccal defect there. And sure, I can ignore that, but if I'm in there and I can manage it while I'm there, it's certainly an easy way to do that and get really, really good results. So I mentioned to you, I always try to leave things open, but the reality is sometimes we do make the decision to get things closed, and it really just depends on the patient. And unfortunately, a lot of my patients, maybe they're not the most type of patients that are really good with instructions, or maybe they're smokers or diabetics and things like that. And yes, there are times when I will try to cover and get closure, maybe not without a large periosteal release, but try to at least approximate the flat margins a little bit closer together, so that I don't have to worry about the patient, disturbing the site if they're not really that compliant. And so here's an example of that. So not every case we do the same, there's no exact cookbook, but again, here's the healing of this one. And again, this was a patient, she was a smoker. And I'd love to tell you, I know I don't treat smokers. I tell them I can't do it. Well, the bottom line is, these people want teeth. They have the right and prerogative to have a tooth replacement. She's, despite being a smoker, she has, a lot of things going on in her life, and she has a job, and she needs to show up to work and be able to smile and feel confident. And these are cases that you guys will all see day in and day out. So I can't just tell every one of these patients that I'm not going to treat you. Obviously, we want to encourage them to quit smoking and give them all those, positive reinforcement. But the reality is you will see these patients. And so for me, especially in these cases, this is where I want to use a material that's, bioprivileged, has those growth factors that are going to help with healing. And you can see that here. So from before and after, we did really, really well. Now for, larger dehiscence defects, here's a case where I went ahead and I used a collagen membrane in the anterior site, and I really just didn't have enough collagen membrane. And so I thought this was a great case for me just to try the Bioexclude for a larger defect. And really I had good bone volume. And that's really the key here. If you don't have enough bone and you're grafting your socket and you kind of feel like, oh, maybe I should open up another bottle. If that thought even crosses your mind, you need to open up another bottle of bone. And so I often joke, I don't even order the 0.5 cc's anymore because I don't want to have that thought process every time. And so I typically will order the 1 cc so I know I have enough bone. But if you have the bone graft in place and you're maintaining the volume, check out how this case healed. And yes, sure, there was a much more severe dehiscence, a very thin buccal plate in that anterior site, which did well with the collagen membrane. But even in that posterior site where I had a pretty large dehiscence and a very wide socket, the O6 Plus did well in the anterior site, but in the posterior site, the Bioexclude did just as well. And our bone completely turned over. And now I have great bone to place an implant. So that's something that you want to consider. Now, the other thing that I learned sort of the hard way is that, and I mentioned this earlier, a lot of times we do bone grafting and we kind of expect that, well, I did my bone grafting, that's it. Next step is going to be our implant. And now that I've been doing this long enough, I've sort of realized that there's no reason why you can't add more, right, at the time of an implant placement. Because again, you always want to create an environment that's going to be the most beneficial for a patient. And if you're in there anyway, and there's an easy, simple way to add just a little bit more bone, I want to do that. So here's a case where I had a much more severe defect than some of the previous ones I showed you. We have a horizontal component on the buccal plate. We have a palatal component as well. And so in this case, I decided to do the sausage technique, and I used tacks and screws to really plump out the ridge. Now, this area of the mouth, for those of you that don't have a lot of experience with grafting, to me, this is the hardest area because you have the anterior nasal spine in the way, you have a lot of lip pressure. And so you really need to overbuild these. And in this case, I did really well. You'll see how it looks when I flap it open, and I can certainly place my implant in that ideal prosthetic position. But the bone was still a little bit, it wasn't turned over as well as I would like. Let's put it that way. And when you look at the extraoral view and the occlusal view, I still had a little bit of a soft tissue defect. And so again, take every opportunity that you can while you're in there to do a minimally invasive or a procedure that has very low risk of going south, right? And so in these cases, I will often use the bone from my drills. I'll do a little slow drilling protocol. I'll harvest some autogenous bone. And why not use the Bioexclude to then protect that bone, keep it in place. And you can see these cases will end up treating out much better if you're taking the opportunity to graft more. Okay. And the next question people will always ask, do you charge for that? That's something that is really dependent on the type of practice you have. I try to make a, deal with my patients, and I say to them, listen, if I have to graft it again later, I'm not going to charge you for it. Now, if it's a case from the beginning that I know I'm going to have to graft multiple times, I probably wouldn't do that. But to me, this is a very inexpensive way to give them more regeneration, to give them a better starting point for the prosthetic. And again, all I did was sausage graft at first. And then 4 or 5 months later, when I went back to place my implant, I added some autogenous scrapings or bone from the drills that from preparing of the osteotomy, and then tuck the Bioexclude to protect that bone graft and keep that bone graft in place. And you can see from picture A to picture B, pretty nice improvement, but I think there's even more of an improvement from that second photo to the third photo. And now I can send this back to the restorative dentist and know that I'm starting off in a very, very good place. Okay. One of the things I really, love the idea of is saving teeth, right? As a periodontist, that's something that's always on the back of my mind. I want to save teeth, but I got to tell you, performing guided tissue regeneration can often be very, very unpredictable. And it's probably the most technically demanding of all the things that we do, because it's just very hard to really clean the root surfaces. and to have a defect that's going to be amenable to doing GTR. And for me, this is, once I started using Bioexclude, I really started finding the passion in doing GTR again, because of how much easier it was to handle. And so here's sort of not really necessarily a run-of-the-mill case. The patient had a little lesion that we did biopsy. And you can see how this case looks when we flap this open. And so the most important thing is to really, really degranulate very, very well in these cases. And then this is why I love the Bioexclude, because I can use a piece of the Bioexclude and I can really fold it over that buccal occlusal line angle really, really nicely. And it'll just sort of suck down over my bone graft. I'm not using a lot of other biologics. I don't really use Emdogain for these procedures. I use the Bioexclude. I will oftentimes mix that Bioexclude, the little clippings, and mix it with the bone, like I mentioned earlier, because to me, that gives me those growth factors. And I always have a little bit extra, so I can always do that. And then you can see the healing of this type of case. This is a nice incision design for these cases, just to try to avoid making an incision, right over the papilla. I'll do a lingually placed incision. And then the other thing you noticed here is I put a little temporary splint there just to hold the teeth from being mobile. If we want regeneration, we cannot have any mobility. And you can see the healing here at, that's only about a week, as you see those sutures haven't lost their dye yet. And here's the case from the buccal view. And so these cases really treat out much better for me, at least in my hands, than when I was, previously trying to use a collagen membrane and trying to trim it and then tuck it, into that very narrow interdental space. That's very challenging to do. And there's plenty of literature on this. One thing I think that's interesting that I've seen lately that I haven't had a chance to try yet is a lot of authors are actually promoting 2 layers of the Bioexclude. So one layer against the root surface, packing bone, and then another layer over the top. So if any of you try that, or if you want a good idea for the contest, that's probably a great way to go. Using this stuff for periodontal regeneration, I think, is something that we're all going to be doing a lot more now, especially when you start to see, these implants that we all thought were, basically, problem-free. Seeing these cases back, and implants obviously can lose bone as well. So I think that might be a good idea for any of you out there that are looking for an idea for a case submission. Try using the Bioexclude like I did here, or in a similar fashion for guided tissue regeneration. I think that's very, very valuable. And here's another example. This is one of my favorite cases. Localized juvenile periodontitis case. I was pretty hopeless in the beginning. I really thought that she was going to lose these teeth. But for me, the best thing I can do for this young patient is save these teeth for as long as possible. And I did not feel comfortable putting her on compromised maintenance. I felt like we needed to do something. So again, splinting the teeth together, cleaning out those defects really, really well. And then just imagine trying to fold a collagen membrane into that interdental space and protecting the bone graft. It's basically impossible. And so using the Bioexclude, I was able to do that, not worrying about the material bunching up on itself. And you can see the healing at about 1 year. She's doing really, really well. I need to get her back in for another x-ray. That she's a teenager and it's hard to get her in. But I really feel like I did her a great service, because even if she ends up losing these teeth later, I mean, getting her through her teenage years with these teeth and trying to preserve them for as long as possible, and even just regenerating that bone, will be valuable later on in life if we do need to do implants later. So something to consider. I don't see any other way for me to have treated this without using the Bioexclude, because again, those interdental spaces are just too tough. And I know there's a lot of talk about using certain other biologics, which I won't mention, that come in a liquid form, but I just don't feel like you're getting that same level of cell exclusivity with those materials. And you're not getting the ability to confine the bone graft to the defect. And I always say that when we teach our GBR courses, that we know, we need to exclude soft tissue cells from growing into our bone grafts, but that's not the only reason for the membrane. The other reason is that we need to confine our bone grafts to the defect. And if you just slop some liquid in there, that bone wants to go everywhere. And having a material that's so easy to use that will drape over the graft is going to be very, very beneficial. Now, I do like to do things that are as predictable as possible. And so here's another case, a little similar, a little bit more severe, but in this case, I'm missing the whole buccal plate. Okay. And I'm a little bit more worried in a case like this that yes, the BioExclude is a little bit flimsy once it gets wet, and is it going to support? And so I like the idea that it will drape over, but I am not as confident in a case like this where I have roots exposed that it's going to hold up on its own. And so in these cases, I will go ahead and use it as an adjunct to a collagen membrane. Okay. And again, I can just avoid trimming it because I know it's going to kind of suck down and hold things in place. And you can see the results of this case also very, very good. Patient had very minimal discomfort, no issues with anything opening up. And she's actually out now a couple of years doing very, very well. And in a case where I really thought we might lose one or two of those teeth. And again, I don't know how we could really treat this without confining that bone graft to the defect. So to me, guided tissue regeneration is a procedure that I stayed away from for a while because I was very challenged and I was very intimidated by the small details of the procedure. But if you have a material like this that will suck down and drape over and provide those growth factors to the area, it's really a game changer for me in that respect. I'll use it all the time. And here's another case. So sure, here's a case where I could use a collagen membrane. I probably could have gotten away with using the BioExclude on its own in this case. But this was also a smoker. And to me, if I have a patient that's not that compliant, why not go ahead and have that extra the benefits of the BioExclude to help me out and help with the healing. I showed you a lot of different types of cases. I know I'm going through pretty fast, but I also want to have time for questions. A lot of the time I'm doing my, bone grafting, my ridge augmentation types of cases with a collagen membrane. If you follow me on Instagram, you know that. But like I mentioned earlier in the earlier in the webinar, nowadays I'm actually combining the amnion-chorion membrane with those cases quite a bit for a couple of reasons. I like the idea of getting some of the growth factors mixed in with the bone, but also it helps with the handling. So here's a case where I extracted the teeth. I'm missing the buccal plate. The remaining buccal plate is very, very thin. And I went ahead and I trimmed my collagen membrane too thin. So it's not extending beyond the margin of the defect. And I tried starting to stabilize it and all the bones started to squeeze out the sides. So, and this was actually the first case where I used these two materials together. And as you can see, I went ahead and took a large size Bioexclude and it just draped down over the area very, very nicely since I did over trim that collagen membrane. And that's very important. We oftentimes will try to trim the membrane without compensating for the fact that you're now going to add this large volume of bone, that large, convexity. And so our membranes end up being too short. And so that's definitely something that you have to consider. You're not measuring from the line angle of the adjacent teeth. You have to really compensate for that. But as you can see here, I got this nice, really stable package now of a collagen membrane, but also the amnion-chorion membrane over the top of it that's allowing my bone graft to stay into place. And when you see the results of this case, which is what I saw, then I started saying, well, I want to start using this more often, which I've definitely began to do. And this case, along with a couple others, are going to be published actually in Compendium, I believe in May. So in about a month or so, you'll see these cases in Compendium. And it's something that I haven't seen published before. But for me, this was a result I wasn't expecting. And looking at even the edentulous site, look how well we did there, growing bone outside of the housing. And could you do this with one membrane? Sure. But for me, it's not just about, the bare minimum that we can do to get the result. It's about making my life easier and also decreasing morbidity for the patient. Here's another example, a very, very, very thin ridge, horizontal defect, but a buccal and a palatal component. And seeing the results from the previous case, I did the exact same thing. It was a collagen membrane layered with an Bioexclude membrane over the top, stabilized with some periosteal stabilizing sutures. And then here was the post-op review. And again, no particulate remnants. And I'm always overbuilding these. And again, in this case, plenty of bone now to go back and place my implant. I don't think you could really get these results without the combination of materials. And I've done it. And again, in this anterior region, it's very tricky because the patients have a lot of lip pressure, or they're wearing a partial that's pushing on the area. And so this also gives me the benefit of, hey, if this thing opens up, I know I have that BioXclude that's going to be exposed, and not my collagen membrane that's going to be resorbed, much more quickly. So it does give you that extra protection. Here's another case that I really love, not the greatest pictures, but we oftentimes are, trying to find a cookbook approach to treatment. And we'll see a case like this that has a very, very severe dehiscence. And we may say to ourselves that, hey, I'm not going to go ahead and do an immediate implant here because I have this severe dehiscence. Well, if I have the ability to stabilize my bone graft, and I have the ability to add growth factors to the site, as you see what I'm doing here is the same procedure I just showed you in the last two cases, using the collagen membrane over the top. In this case, I think it was an Ossex Plus, and then the Bioexclude over the top of that to help confine everything in place. Check out the healing of this one. Okay, so this is very consistent. I think this case is also going to be in the compendium in that same case report article, but just showing that, it's not such a cookbook approach. You have to look at each case independently. This case, I felt pressure on the patient's end because he was getting married. And so there's always those little contributing factors that say, you say to yourself, well, let me try to do this for you. Obviously, we know that there's risk when you're treating a severe dehiscence like that and putting an implant in simultaneously. There's always a risk that you could lose some of it. So I want to overbuild these cases. I'm going to put bone over my implants like I showed you, and then I'm going to use every bullet I have in my gun to try to obtain this result. And you can see the before and the after of where we were versus where we are 6 months later. And we've not only, have great bone around our implants, but I have that critical bone thickness that I need buckled to my implants, despite the fact that I had that severe buccal dehiscence. Okay, so I've showed you a lot of different ways of using it, and this is probably only scratching the surface. For any of you oral surgeons out there, I know a lot of the oral surgeons that I know, they're using it for nerve wraps, they're using it for their zygomatic implants and things like that. I'll tell you that my own experience is that it's probably the best material for these Schneiderian membrane repairs. I do use PRF, but I love the idea that this material comes in so many sizes, and so it can adapt perfectly depending on the size that you choose. So here's a case where I had a small perforation. I go ahead and use that 8x8 just to operate that opening. And then you can see from the post-op radiographs that it certainly kept my bone graft from going into the sinus, and then my bone turned over really well. I did this case recently, and this was a very tricky anatomy to this lateral wall. And what happens is a lot of the time, even though you sort of know that the anatomy is tricky, this is typically the place where I'll perf in this distal apical line angle. And so, what are we supposed to do when you start to see a perf? You're supposed to make your window a little larger and work your way around that window to free it up. But sometimes you start doing that, and that window that opening, that perforation just gets larger and larger. And so that's exactly what happened here. And so as Mike Pico says, never abort a sinus lift. And so I'm going to go ahead and I'm going to take a large Bioexclude like I did here. This is a pretty large size, but I really want to make sure that I keep my bone graft in the sinus and not have it go up into the membranes, the perforated membrane. And so you can see my bone graft here. This is sticky bone, I believe, but just to pack into that sinus without fear of that material going up into the sinus. And then, of course, I'll always use another piece of the Bioexclude over that lateral window, and then get primary closure for all of my lateral wall sinus lifts. And I just saw this case last week. We did the implant placement, sort of an atypical presentation for an all-on-4 case, but the bone was very, very thin in the anterior. So I did my lateral walls first. And again, there's no cookbook approach. Sometimes you have to do it this way to be more confident, to be able to get teeth more posteriorly. And so I went ahead and placed 6 implants in this case. He had a very wide arch, so I went ahead with 6 implants. But those posterior implants are have great bone around them because I did those sinus lifts first and didn't force the issue. And you can see how anterior that sinus that goes on the patient's left side. And so it really was not a great case for just 4 implants. Sometimes you have to stage it. The last thing I want to show you is just the idea that, this really does speed up the healing. And it's always hard to prove that, because of course, everybody heals, patients heal, but it's very difficult to really examine, what materials are causing the increase in healing. But one thing I've noticed nowadays, especially now that I started doing a lot more deepithelialized free gingival grafts for my connective tissue grafts, is that I'm harvesting from the palate a lot, and I'm removing the epithelial layer. And so I'll often do this by just harvesting a free gingival graft, and then, as you saw in that video, I'll remove the epithelial layer out of the mouth. And the reason for that is I want this high quality tissue, as opposed to, doing a single incision technique. And I tend to get much deeper tissue, which has a lot more fat in it, and it's not as good tissue. And why am I doing this? Well, typically I'm doing a lot of tunneling nowadays for my soft tissue grafts. And I find that I don't really want to create a separate incision if I can avoid it, but it's often very difficult to tuck that connective tissue, without an extra incision if it's too thick. So typically I'll do this free gingival graft approach, and then I'll deepithelialize, and that allows me to really tuck very nicely without any, vista incision or any vestibular incision. And I'm getting really, really nice healing. So there's plenty of lit out there now talking about the high quality of that deepithelialized free gingival graft. And you can see here at 5 months, I even got some creeping attachment, and the case is doing really, really well. And so we all know that free gingival grafts will heal. And here's a large case from a couple of years ago, but just to show you the healing of the palate after about 10 days. And this looks like it hurts. And sure, it does. And that's what a lot of us, clinicians that have some experience know, is that patients hate the feeling of the palate being denuded. And so we certainly have tricks to around that. And I use a lot of periacryl in my practice for just this reason, just to protect the palate from the patient playing with it. And studies do show that it reduces the patient's pain and discomfort after the procedure. So one of the things that I wanted to do, though, was try to incorporate Bioexclude into these harvest sites just to improve it more and sort of test whether or not I was getting better healing. And so here's a perfect example of how I'll do this. Basically, you can use pretty much anything. You can use a collar plug. You can use, collar tape. I typically like the plugs because I can squash them, and they're usually a perfect size for my free gingival graft harvest. And then in this case, and a couple cases that I'll show you, I'll wrap the Bioexclude around the collar plug, and then I'll basically just place it right into that area. And then I'll either place a couple of sutures to hold it in place, or I'll put the periacryl right over the top. And these cases really just amaze me with how well they healed. So take a look. Here's another example of how I'll do this with sutures, just a continuous suture, just to hold everything in place, and then the periacryl over the top. And you can see the healing of the recipient site, but look at the healing of the non-recipient site, the donor site, at that same 7 to 10 days. And I know this is 7 to 10 days because, again, those sutures still have their dye. These are glycolon sutures that come dyed, and usually at about 2 weeks, they start to lose their dye and become clear. And so at 7 to 10 days, that is healing that I had never seen before. And to me, there's only one reason that could account for that. And it's not just one case. It's not a one-off. Here's another case, same thing. Also, look at the sutures. They're still dyed. So this is, again, only about 10 days post-operatively. And patient's a good healer. You can see that from the way that the free gingival graft healed. But look at that palate. And that almost looks like a single incision technique when that was a free gingival graft. So clearly it couldn't have been a single incision technique. That had to be the benefits of the Bioexclude lending to the healing. And of course, we know palates will always heal. I've never had a patient that didn't heal and the soft tissue didn't heal over on the palate. The body does not want bone exposed, so they will heal. But for me, seeing that these results are pretty consistent in getting a much better healing using this, that can only be accounted for by the Bioexclude. So just a tremendous amount of benefits. And it's really that versatility that I love. And one of the things that we always joke around about is, we have so many different products and materials and companies that are pushing things on us. But again, we don't want to experiment on your patients. You want to do things that are as predictable as possible, but it's nice to have products that have multiple uses. And so for me, it's one of those materials that I'm using every day, day in and day out. And I showed you a lot of different usages for it. And there's probably so many more that I haven't even thought of yet. But like I said, some great usages maybe for you guys to think about using for the contest would be those periodontal plastic surgical procedures. I think a lot of people are using that more. And the non-surgical periodontal therapy, I think, is going to be a lot more popular now, that more people are being aware that this can be used for that purpose. there's probably a lot more indications, like I mentioned. The real thing about this material is that it's a benefit of a barrier and a carrier. So it helps to exclude soft tissue cells, but it also carries the growth factors in it. So it's not like a collagen membrane that's just acting like a barrier. And again, it's not like a biologic like Gem21 or Emdogain that really just has the growth factors and really doesn't help to hold things in place. So I think it's important that you practice with the material in the easier cases, because again, it does handle differently than almost anything else. But if you get the hang of it, you'll see that it really does adapt really well. It adheres to the native bone very, very nicely. But remember, use it dry. And when it's in place at the site, that's when you want to hydrate it, and you'll really get the benefits of the hydration. And I know we have some good questions that came in. I sort of was looking over it, so we'll definitely take some time on that. But if I don't get a chance to say it, thank you to all of you for joining me tonight. I really appreciate the invitation from Snowasis and Matt. And if you guys have any questions that you haven't written yet, now's the time. This is a nice slide that just goes over some of the classic lit. And there's been so much more lit, actually, Matt, even since I put this slide together a couple of years ago. I've seen so many great articles out there lately. But if any of you are interested in getting some ideas for the contest or just seeing the lit, here's a good list of articles that I used for my citations for some of the articles that I've done. So again, thank you so much. I'll take a look at some of these questions. And Matt, if you have any housekeeping or anything you want to do.
No, I just want to thank everybody again for coming. And yeah, to your point, I believe we're up to 54 or 55 publications to date now. So we definitely are starting to prove the science.
Yeah, it's pretty amazing. I mean, everybody's coming up with even new usages of it every single day. So I really love that. And look, there are some great clinicians. Dr. Hyde Perio uses it a lot for his ridge augmentation cases, and some of the results are just incredible. I saw John Kim posted an incredible Bioexclude case for maxillary anterior ridge augmentation. It's just really a matter of getting used to the handling of it for those larger applications, and maybe combining it with something like sticky bones so that you can really maintain the volume very nicely. And again, for me, if I can get rid of using titanium, getting rid of using screws, and even the stabilizing sutures, I think that's a huge plus, right? All those things add complexity to the procedure and can definitely, lead to more complications. So I love the idea of all resorbable materials, and this definitely falls under that category.